Thank you very much for the invitation. Thank you very much for staying. This is the last talk of the day. So after this, we go for the dinner. Following from the previous talks, we decided we're going to do a reverse. But is the reverse just for calf arthropathy, or are there more indications? Up to very recently, calf arthropathy was the main indication for reverse, but this is expanding. And if we look at the Australian registry, we see that osteoarthritis now is the most common indication. It's no longer calf arthropathy. And this has been similar for the last 8 years. So there is a significant progress or movement towards treating more than just the calf tears and the calf arthropathies using a reverse. And we used to keep the reverse for the older patients. There used to be a trend, this is for old people with calf arthropathy, but now it's trending to younger and younger ages because it's a tool that can be used to solve a lot of problems in shoulder surgery. But before looking at the differences between the various indications and uses of the reverse, we have to see what is the same, and these things stay the same. We always have to examine our patients, we have to assess the patient factors, we have to do proper imaging and preoperative planning, and we have to know the implants we'll be using very well, because these are the main tools that we will use to provide our patients with the best possible treatment, not the indication of the reverse. So if we decide to proceed with the reverse, this can be done into different scenarios. It can be a primary reverse or a reverse for a revision. I'm not going to delve a lot into the reverse for a revision because in cases like that one on the screen, we know we have high risks of complications. We may require special implants. We may require grafts. There may be more than one stages into our process of using that reverse. So I'm going to stay more focused into the primary uses. And again, out of the primary uses, there are three main scenarios where we'll be using a reverse. It's osteoarthritis, rotator cuff arthropathy, and fracture sequela. All the rest are very uncommon indications and do not allow for a good statistical analysis if we delve into those. So what are the differences, or more, what are the important differences? Because there will be lots of different small details in all of those indications and implants we'll be using. So I will look briefly into the expected variations and technical problems we may encounter, and then using a reliable registry, and I like the Australian registry for this. It's very well detailed, look into the outcome and possible complications we encounter if we use the reverse as a tool to repair different pathologies. And we start with the soft tissue around the indications we'll be using. So the reverse is first and foremost a soft tissue procedure. We aim to balance tendons and soft tissue around the shoulder joint to allow function and movement. And there we have significant differences between the three main indications. When we have calf arthropathy, we usually do not have calf, otherwise it won't be calf arthropathy. If we do it for osteoarthritis, the calf is present, and when we do this for a fracture, the calf or the remnants of the calf are on the tuberosities. The subscapularis may be injured in the calf arthropathy or may be absent, whereas the subscapularis is present and functional in the osteoarthritis scenario. And it's on the lesser tuberosity when we deal with a fracture. Similar situation with the biceps tendon. And then the teres minor is an indication of whether a calf arthropathy reverse will do well, whether we need tendon transfers. It's usually fully functional if we do it for osteoarthritis, and again, it's part of the fracture and the fracture pattern if we do it for a fracture. And then the nerve situation is also important. You have more nerve injuries if you deal with a fracture and a fracture dislocation scenario, whereas the deltoid muscle is usually well functional in the other two cases. And this is a brief description of what you will see if you open a shoulder with the three different pathologies. So even the approach that we'll be using might differ depending on the scenario or the situation we'll be dealing with. Especially if we wanted to do an anterosuperior approach, we can easily do an anterosuperior approach and even leave the subscapularis intact if we have a scenario for calf arthropathy, because the whole thing will just come through the calf there like the image on the left on your screen. But still the bone is important. We have differences in the bone scenarios or the things we expect to see between the three different main indications. When you have a calf arthropathy or osteoarthritis, the proximal humerus is almost always intact, whereas you have bone loss if you deal with a fracture scenario, and you need to account for this and use a stem that is more suitable. So we can use small stems or metaphyseal fixation for osteoarthritis and calf arthropathy. And if we go on the glenoid side, usually in the fracture scenario, the glenoids are normal. In fact, in the Australian registry, they're all type A glenoids, so it's extremely rare to have glenoid issues. Contrary with osteoarthritis and calf tear arthropathy, but more common with osteoarthritis, you need to consider your glenoid and see whether you need to augment it and what kind of augmentation you're going to use for that. And these are the glenoid considerations. They're extremely important because there's a lot of research and a lot of problems that may come out if you don't address your glenoid appropriately. So in the VALS classification, almost all of the fractures fall into the A1, rarely it's an A2. The Cerveau classification modified by Favar is extremely important if you deal with calf arthropathy, not as common though if you're going to deal with osteoarthritis. And for the osteoarthritis, there's a lot of discussion, a lot of things we need to consider, especially around the B2 glenoids. And these are some scenarios. This is an osteoarthritic shoulder with a B2 glenoid. The head is posterior subluxate, so the most useful prosthesis for something like that would be an augmented base plate with a short stem reverse. And then if you have a fracture scenario, you need to consider longer stems usually, like the situation on the top. But if you use your implants for osteoarthritis, and this is a verso, this is the first stemless reverse that was designed, then you don't need a long stem because you have a lot of metaphyseal control. But despite all the things I said, there are some exceptions, and the bottom right scenario is it's an exception of all the things. So it's a fracture dislocation with enough metaphyseal support to do a short stem, but with a destroyed glenoid. And in that scenario, you need to augment or use a graft for the glenoid. In this, we use the actual head as a graft to repair the broken glenoid. And then you need to access the axillary nerve and whether you are allowed to do a reverse with an axillary nerve that is non-functional. And this is the same for all three scenarios, but it's a lot more common in fracture situations. And whether you can do a reverse despite a non-functional axillary nerve, there are some questions around it, but the research says that yes, you can do it. You can expect the nerve to slowly function, and the outcomes are not that bad. Even though you can expect early dislocations, you need to be aware of that and address it if it happens. And then if we look in the outcome and the possible complications, if we do a reverse for instability or rheumatoid arthritis, then there's a high risk of revision. The fracture has high risk of revisions, but only in the first 3 months. Once things settle down, this risk becomes a lot less. And usually, the most common scenario is you have instability, and this is what you need to address in your revision situation. And this is a cumulative percent of revision, so you see where the rheumatoid arthritis and the instability for reverse come as an indication for increased failure rates. And then, what are the differences in the outcomes or the revision rates you can expect depending on the three different scenarios we talked about? So the age is not a predictor for failure in the scenario of calf arthropathy, but in osteoarthritis and in the fracture scenario, the younger patients have a higher revision rate. Sex is the same in the calf arthropathy situation, and all this data is from the Australian registry, whereas male have a higher incidence of early failure, but once the first 3 to 9 months pass, the things equalize. The ASA, again, is a predictor only for the calf arthropathy, whereas the fractures have similar behavior and failure rates. The BMI, this is a very strange. The only place where the BMI plays an important role is pre-obese patients that seem to have low revision rates in the scenario of calf arthropathy. The glenoid type doesn't make a difference, and the fixation that we use, whether it's hybrid, cemented, or anything, again, doesn't make a difference. And the last bit is the most important one, or it could affect what we plan to do. So in the scenario for the calf arthropathy, the glenosphere size doesn't play a role. But smaller glenospheres fare worse if you use them for osteoarthritis. And very big ones fare worse if you use them for fracture. This is sort of intuitive as well, because if you try to fix a fracture, you may be tempted to put a bigger glenosphere because there's more space there. So you always need to reconstruct your humeral side and base your glenoid onto the reconstruction of your humerus in order to avoid mistakes like this. And it's very important to know your implants. So there are some implants or implant combinations that have a high risk of failure irrespective of where you use them or what scenario you use them for. This is just one, the SMR axioma from the Australian registry. This is a very good registry, no matter what kind of joint replacements you do, to look into and find out implants that you may be afraid of, or look into whether they have some higher risk. So in conclusion, pre-op planning and preparation for all the soft tissue and bone differences is extremely important. You need to be aware of the small differences in revision rates between all the indications. So younger males have a higher risk of failure in osteoarthritis and fracture. The glenosphere size is important. So be aware of what kind of glenospheres you implant depending on the diagnosis you use them for. And revision always has worse outcomes. But in general, the reverse has, at this stage now, become a very good tool. They have a 93% survival in 10 years. And these good results become stable after 12 months. So you need to wait around 12 months, 12 to 16 months before you know how much improvement or how better the patient will fare. But there is a deterioration, and this starts to be obvious after 2 years. And this could either be due to patient aging or a deltoid impairment and fatigue, which is, again, something we need to consider when we use and decide what kind of implant we'll be using. And with this, I'd like to thank you with a few messages from Canterbury and our new medical school. Thank you.